60-year-old male alcoholic patient presents to the outpatient clinic with the primary complaint of painless bleeding upon defecation. Upon physical examination, the physician notices that the patient has a distended abdomen with engorged superficial veins radiating from the umbilicus, also known as caput medusa. This is most likely resulting from portal hypertension. Which of the following embryological veins has become patent again and is most likely responsible for the development of caput medusa? Portal hypertension is a key concept that you want to be comfortable with. Therefore, you want to understand the three things we need to be concerned about with a patient with portal hypertension. One of them will be esophageal varices. Number two, thinking about internal hemorrhoids. And number three, that's going to be caput medusa. The key thing is to be aware of the portal aspect of the veins that will be engorged, and then the caval aspect of the veins that are also going to be involved for each and every condition that we discuss as it pertains to portal hypertension. In this case, they're talking about caput medusa. And you want to be aware of the fact that when you have these high pressures within the portal vein, that can cause my ligamentum teres hepatis to become patent. And once it becomes patent, it's going to be the umbilical vein. We've pretty much recanalized my umbilical vein. And these are going to be known as the para-umbilical veins. Therefore, when approaching this question, you want to be able to pick up that fact. When you look at portal vein, we know that portal vein will be involved in portal hypertension. However, in answering the question, it's asking which of the following embryological veins is patent again. Portal vein has always been there, so we eliminate it. The superficial epigastric vein, that's going to be involved, yes, in the caval aspect of caput medusa. So let's keep it maybe. Left gastric vein, that's going to be present in my esophageal varices, not this condition. Eliminate. Internal iliac veins, that's going to be involved in my internal hemorrhoids. We can eliminate that too. Now we've got paraumbilical veins and superficial epigastric vein. They are both going to be involved in caput medusa. However, the best answer here is the paraumbilical veins because they have become patent again due to these high pressures. It's important to understand portal caval anastomosis. First of all, in portal hypertension, there are going to be three main clinical signs that we're going to be worried about. The first one is going to be esophageal varices. This one is going to be the more serious clinical sign that we're going to worry about, especially in patients who are in later stages of liver cirrhosis. So what you have here is you've got the elevated pressures in the portal vein. This is going to cause a backflow in the blood that's going to be from the left gastric vein that usually drains in the portal vein. And what you have here is that's what we're going to call the portal aspect. The left gastric vein is going to be the portal aspect of the esophageal varices. As this blood builds up, our vein is going to be engorged, and we're going to have the buildup of blood near the esophagus, right? Especially the lower end. And you want to be aware the veins draining the blood, the distal part of the esophagus, the lower esophageal veins, they are going to be the caval aspect of this portal, caval anastomosis. Therefore, they're going to be draining into my azygous system. And when you say caval, we mean that this is going to be bypassing the liver. That's why we mentioned this as the caval aspect. So you want to know that for esophageal varices, the portal aspect will be the left gastric vein. The caval aspect will be the lower esophageal veins. These veins will bulge into the lumen of the esophagus. And once these veins are going to rupture, that's when you're going to get the classical hematemesis in someone who's got ruptured esophageal varices. This is a very dangerous clinical complication that we would like to avoid at all costs. The second clinical sign we will discuss is in regards with internal hemorrhoids. When a patient has internal hemorrhoids, you want to remember that an internal hemorrhoid is going to be a painless bleed. This is because it's going to be above the pectinate line, and that's going to be visceral innervation. So you want to be able to pick up the clinical signs when a patient has internal hemorrhoids. You want to know that the portal aspect for the internal hemorrhoids is going to be your superior rectal vein. That superior rectal vein drains into your inferior mesenteric vein, which will eventually drain into your splenic vein. Remember the saying, two S's make a P. That's why downstream we are going to have the builds up in pressures, right? So what I want you to know is portal aspect for my internal hemorrhoids will be the superior rectal veins. The caval aspect is going to be the middle and inferior rectal veins. And you want to know these will be draining into your internal iliac vein. Therefore, the key thing to know, like once again, the caval aspect will be bypassing my liver. That's why we're going to have the engorgement of the veins once again, and they are also going to build up and bulge into the lumen of the anal canal. When that is happening, you want to be aware of that's when we're going to have my internal hemorrhoids. The last clinical sign we're going to talk about is regarding the caput medusa, and this was the one that was mentioned in the question that we just did. So you want to remember once again, for caput medusa, we're going to have elevated pressures in the portal vein, which is going to cause the recanalization of my para-umbilical veins. Remember, this will be the portal aspect. And then we are also going to have the engorgement of the area surrounding the umbilicus, and the caval aspect involved will be superficial epigastric veins. You can use this table to understand the key aspects for the portal and the caval anastomosis for each clinical sign. Feel free to like and subscribe to the Med Tutors YouTube channel. And also, if you have any questions, you can contact us on the medtutors.net Gmail, located in the descriptions below. Thank you.